without further ado, I'm going to turn it over to the clinical staff here presenting with us, Dr. Rizopoulos, Dr. Rawat, Dr. Cahoon, Dr. Buchanan. Vicki's here. It's awesome. Thank you very much. And at least those three are going to be presenting today. What is the clinical role of MSK-US and EMG in PT practice?
So EMG and ultrasound or musculoskeletal ultrasound, they are extension of clinical examination that all the clinicians do regularly with as they see the patient for the first time. So after you examine your patient, you have a list of differentials. So you know, okay, it could be possibly so and so pathology or so and so structures. For example, in shoulder impingement, we know that there is an impingement. The patient presents like that. The clinical presentation is consistent with that. But do you know what's causing that impingement? To look into further into really pinpoint that structure, if you add ultrasound, you can find out what structure is impinging. Is it calcification? Is it the tendon? Or is it a bursa? Now, speaking about EMG, we know that neck and shoulder, they are interrelated, and sometimes neck and shoulder pain can be confusing based on like the clinical presentation, and a patient may present with shoulder pain, but it may be a radicular pain. So if you add these tools, EMG or ultrasound, you are better able to understand the problem, so you have more accurate information, which leads to better management of that patient. And we have many cases where there are so many examples, and I'm sure the other speakers here can also like give you some specific examples. Some of them we have published also in JOSPT, where when you add these tools like ultrasound or EMG, you significantly improve the management of the patient, because now you understand the problem better and you can direct the patient in the right direction. Would you like to add anything?
Absolutely, if you don't mind. From my point of view, of course, I'm in total agreement with you, Mohini. I'm biased, of course, right? So what do you expect? But nevertheless, many times I've been approached by other physical therapists, and their argument is that pain doesn't correlate with tissue, or pain doesn't relate with a specific location. So doing ultrasound on a knee because there is any pain doesn't mean that you're going to find anything. And of course, that's the case. The pain travels. Everybody knows that. And whoever deals with trigger points, we know very well that you can have these pain patterns that, a neck problem can send pain all the way down to my arm. So yes, that's so true. At the same time, though, it is so important to really see what's happening with that joint, talking about the ultrasound. And I was thinking about that because, we ran a survey lately, and I saw the same thing in one of those answers as a response. And I'm like, you know what? What about if we perceive ultrasound as a prognosis, as a tool to foresee a problem? And we know very well, for instance, in rheumatoid arthritis, ultrasound can be a great tool to catch it early. So before we see that destroyed joint, we know with the use of ultrasound that there is a potential that we're moving towards RA. So the doctor, the MD, can do the appropriate, management on this case. That's one. Or let's say you have an ankle pain and you do an ultrasound on that Achilles tendon, and you see this humongous tendon, you know that this is gonna, torn eventually. So if you know that, you can do something about it before it happens. So that's my counter argument. Ultrasound can be also a tool for prognosis in physical therapy.
It's interesting that you mentioned RA, because last night's presentation by Vicki was on RA.
There you go. Vicki, I'm sorry.
Yeah, she presented on all those changes that you mentioned, early changes that you can pick up with ultrasound.
Yeah, absolutely.
So, yeah.
Yes, so last night my presentation to our clinical group was specifically on the ways that ultrasound can help the physician manage rheumatoid arthritis. And specifically, most of the patients that I scan are already seronegative for RA. So the physician's a little bit at a loss as to, what condition they're in because they're seronegative to begin with. And so once I can scan the joints of the hands and feet and then other painful joints, but primarily the MP and MTP joints of the hands and feet, I can tell exactly what's happening in the joint and help the physician figure out how to better manage that patient. As well, it's a very high predictive value for what that patient's going to look like in a year before X-ray can actually pick it up. And most of the literature now is showing that musculoskeletal ultrasound is more sensitive than even MRI with contrast. It will show earlier changes because you can just see more of the structure. So yeah, it can be an extremely useful tool for us to help in the management of those patients.
Yeah, and also to circle back to what Kostas said about prognosis, they are also using it for prognosis. So you monitor how a specific treatment is helping the patient, especially when you have those early RA changes and it has not reached that stage of like erosion and those permanent bony changes. You can really reverse it with proper management.
As well, I've actually had a couple of patients that the thought was that they had RA, and when it was all said and done, they had some calcific depository type arthritis, like a gouty or a pseudogout arthritis, which actually changed the way that they were being treated and significantly improved a lot of their joint pains, not just in a couple, but actually improved a lot of their joint pains. So we were able to kind of catch that early on and change that course of treatment to better help that patient.
That's awesome. That's awesome. No, it's interesting, Vicki, on what you said, and you, Mohini, that from a philosophical point of view, physical therapists have a great responsibility over the patient, more than MDs. Especially now, patients go to their doctor, they spend really just a small amount of time on a hands-on experience, try to figure out what is the problem. Most of the time, it's in front of the computer documenting what the patient feels. And then they've been referred to us to manage something that sometimes is unmanageable, So the more we know about the case, the better we can manage these patients. And it is, again, because physical therapists are very ethical, and I believe that, we assume that responsibility. So I personally, I'm much better in what I do being using ultrasound than, let's say, 8 years ago when I started, before I started doing ultrasound. So no matter what, it has helped me, at least as a physical therapist, to be not only better as a clinician, but, cause changes, help my patients. That's priceless.
Andie, would you like to add to that?
Amen. No, I will say, to go along with the clinical exam, I mean, how many special tests do we have to do to figure out a problem? Unfortunately, a lot of our special tests don't have great sensitivity or specificity. And so adding on the diagnostics just further pinpoints the problem so that you can treat it a whole lot better.
Additionally, kind of what Kostas was saying is, you don't know what you don't know. And sometimes even if the special test is positive and you've got the right structure, do you know if the tendon is hot and swollen, or if there's a big chunk of calcific deposit in there that might be, causing further joint pain that would change how you're going to treat that patient to preserve the structures of the tendons. And so, I mean, just because we've isolated it, even if there's great specificity of the test and sensitivity, ultrasound can change how you're going to treat, the course of the treatment that you're going to do with that patient.
Definitely.
And all those of our, although people present here, I know we are biased towards ultrasound, but we also mean EMG. Wanted to point that out. We just got carried away with ultrasound talks.
Do we have someone that can come on the EMG side?
So actually all this applies to EMG too. Like Kostas mentioned, someone has knee problem, and sometimes these are referred pains, and when you have pain at a specific area of your limb, maybe upper or lower extremity, sometimes it's confusing and people treat it locally, but problem is in the spine or that specific nerve root. So again, you have both the tools, you cannot go wrong, because now you can look at structure as well as function. So like EMG is like, checking the electrical system of the house. So this is the problem, but you don't know exactly what it looks like. So now you have this extra set of eyes to look inside the body, and you can check what's actually causing the structure that's causing the problem. We know functionally something is wrong with EMG. So EMG and ultrasound have great application in focal neuropathies. That's why they are really useful as tools, adjunct tools with each other. So you do an EMG and you find there's a focal nerve problem at a specific site. And so now we know, okay, this is a focal entrapment, and it's graded as mild, moderate, or severe. But is it compression? Is it idiopathic compression, something that has developed over the period, or is it something because of a secondary cause? It can be a space-occupying lesion. It can be overcrowding of that small area where the nerve is sitting. So you add ultrasound and you know more about it, and you will treat space-occupying lesion case or overcrowding as something entirely different than just garden variety focal neuropathy. So and then if you do not have these tools, you just club everything in one under one umbrella, and you treat them. So it's more of a generalist approach. You're not really very specific about the type of treatment approaches that you will be using in these cases. So you really tease that out. Would you like to add any cases where you found something which you were not expecting, maybe with EMG or ultrasound?
So one case example is we had a patient who was referred here with neck pain and numbness and tingling in the hand. And so they were referred for cervical radiculopathy. Unfortunately, they were not referred for diagnostics, and she was treated, and her neck pain was better, but she still had numbness and tingling in her hand. So we ended up doing the EMG and nerve conduction testing, and she had carpal tunnel, but that wasn't treated for about a month of therapy. And if we had known that from the beginning, we would have been able to treat both. Because of her insurance, she had a really high copay, and so she wasn't able to come in anymore. So I did feel like that patient didn't get the full treatment. So the importance of doing the testing right away is just so vital.
That's a great story, by the way, and it tells you so much, because we know very well that physical therapy works best when we do something on time, right? The more we delay approach, the more we delay our intervention, whether it's us, whether it's the system, whether it's the doctor, whoever is behind that delay, results are not good. And of course, at the end, the person that suffers is the patient. So I totally, again, biased or not, doesn't matter at this point. It is true that the more we know in the beginning of a case, the better it is. Not only that, you can do better treatment. I've seen cases that I was not able to treat. I had this 45-year-old female that suffering with severe shoulder pain. She went to the doctor. Doctor thinks it's just arthritis. She comes to me, and we didn't do the ultrasound the first day. We did it on the second one. So from the first treatment to the second one, of course, she comes in with the same symptoms. And I did the ultrasound, and it was a massive rotator cuff tear. I'm like, doc, I'm sorry, I don't know if I'm going to be able to help this patient. So what about if I send them back to you and reevaluate the whole scenario there, and let me know what you want to do with her? Because again, it was so bad that in my opinion, it needed, surgery than anything else. So again, even if I was not able to help the patient, I was able to, with physical therapy, I was able to help her case. So something can happen sooner than later. That's the idea.
I had a case that was a patient who actually had an Achilles tendon repair, and he had been out mowing the lawn. And of course, he didn't want to wear his boot because it was summertime and it was hot. And so he took his boot off to mow the lawn. And he had gone in the house to get a drink of water, came back out, stepped down off of his step with his good foot first, had instant pain, said he had a pop in his ankle, followed up with his physician a week later, and she felt that the repair was still intact. And so she referred him to physical therapy for 6 weeks. And when he got here on his first visit and told me the story, I said, you know what, I just want to look at it, on the musculoskeletal ultrasound. And I was able to identify that it was a complete re-rupture of the tendon, and wound up sending him back to the physician rather than doing 6 weeks of physical therapy with him, which after 6 weeks, who knows if she could have actually, repaired it and pulled it back down from it being retracted for 6 weeks. And so by the time he went back into the physician, which he got in within a week, she actually did a second reconstruction on his Achilles tendon, so second repair. So, I mean, it saved him, again, 6 weeks, and who knows if it could have been repaired after it was all said and done. So, I mean, that was just one. He had enough plantar flexion that she kind of felt like it was still at least partially intact. But when we did the ultrasound, it was a complete re-rupture. So, I mean, I felt really good about being able to get him back into the physician for his second surgery.
Got it. Yeah.
So we also want to talk about the professional recognition. Physical therapists are able to perform both these tests and bill for it. And there are also credentials for both of these tools. So let's talk about that. For EMG, we have ECS, which is one of the board certification offered by ABPTS. ABPTS is American Board of Physical Therapy Specialists. I'm sure you're aware of OCS, which is orthopedic, the most common one, the most popular one. And there is ECS, that's another board certification, and that is related to EMG. So that's one recognition. And for ultrasound, we have something called RMSK, which is not offered by APTA or ABPTS, but it's something that's offered by some external organization, Alliance for Physician Certification and Advancement, APCA. We also have our in-house fellowship program at HARDS, which awards credential FMSK. So I'll keep the floor open if you want to add something to that. So let's talk about professional recognition and your ability to bill and perform these tests.
If you don't mind, just to add here that RMSK is not required for physical therapists to perform ultrasound. So majority of states, their Practice Act allowed us to use ultrasound for diagnostic purposes, right? But the RMSK, it's a nice title to have if you want to, but it's not a requirement. Reimbursement is not attached to that. But what is important for physical therapists is to really put the time down and learn ultrasound. And whoever has dealt with it, it is fascinating to begin with because you can see the problem, but there is a learning curve like with everything else. And it takes some time before you become really familiar with pathology after you know what normal is, of course. But again, that was my point, that RMSK is not important. As the most important part is to really dedicate the time that you have to really become the best in that specific tool.
That's right. I think that applies for even EMG too, except like Medicare. I think PTs can do EMGs also without being ECS. Would you like to say something on that, Andie or Vicki?
I think just so I have my FMSK, my fellowship of musculoskeletal ultrasound, and I think just having that has helped me to be more credible to my physicians and my patients. Again, not that I have to have that, but it shows that I've put in enough time and passed some tests to be able to, more accurately read the scans and just puts them at ease that I put in the extra time to go the extra mile to get that. So, I always think those are important to just show that you have, like I said, put in that extra effort to be the best you can be at it.
just to add on what you said, Vicki, the FMSK became FMSK, and of course Mohini can talk about it for hours, on the need to put together something so effective from a learning point of view. So a therapist, not only a therapist, an MD, whoever wants to learn that, can really go through the whole program and feel confident that at the end they will be at a high percentage of performing and feeling confident about the results they get. Mohini and myself, before the FMSK, the fellowship in musculoskeletal sonography that Mohini put together, before that, we both learned left and right, on our own, going to some courses and practicing on ourselves and practicing on patients, and it was not fun. There was a lot of stress there because it was not specific enough. So learning can be something that you can take it and use it the same day when you go back to your clinic. So that's what FSK offers.
I have my FMSK and my RMSK, and I don't think doctors have any idea what that means, but I agree with what's been said about whenever we get some negative feedback, we have something to show for that. And I think even with some resistance from the doctors, most importantly, we are doing the best that we can to help these patients. And yeah, as far as the recognition, it's great to have that as like a backup.
So yeah, there is recognition, but I think there is a lot that goes into that recognition. You cannot just get, you feel like you want to get the recognition, you cannot get it. It's a process, and we all know that whether you are ECS, RMSK, or FMSK, there is you have this learning journey, and then you achieve those credentials. So I want to talk briefly about the program that we have for fellowship for ultrasound. I think I'm not the right person to talk about the fellowship and residency for EMG that we have. Probably will cover that in future town hall meetings or webinars. For FMSK, we have 3 main in-person modules. So we divide it into upper extremity, lower extremity, the first 2, which are the first 2 modules, 3-day each, so 6 days. The last module is an advanced module. You don't attend the last module back to back. So first you come for upper or lower, whichever is first, and then you practice. You have ongoing mentorship where you get case-based feedback, and while you're doing your exams, you're also receiving this ongoing mentorship. And we have some online course content which you can attend. So it's not like a long gap between the 2 modules when you come back and you go back to your practice. And we have other educational activities. So total activity hours that you earn by the end of the fellowship is 710, which includes our webinar presentations and case presentations. Then when you come for the last module, which is the fellowship module, we cover some advanced structures and also like try to tie everything back, whatever you have learned so far in that 1-year period. It takes like about 1 year minimum, 1 to 3 years to complete it. And you take a written and practical exam. Now this practical exam is not something that is offered somewhere else. RMSK is 100% theory. It's a written exam. In FMSK, we have practical part as well as theory. So you have a written exam, which is 50 multiple choice questions, but we also have this practical exam. So our focus with fellowship is more on practical learning and more practical, something that you can really incorporate into practice. And because it's tailor-made to your practice, so the kind of patient that you see, you receive feedback on those patients. Do you want to add something? Maybe if I missed something here.
I think you just expressed everything to why the whole thing is being put together. And again, the purpose here is to make sure that for whatever it's worth, I have a belief system that physical therapists, they have kind of inferiority syndrome. Not all of us, but a lot of us, when it comes to MDs. We see an MD and we feel like, oh my God, we're totally, MDs are going to fall on us or something, like the sky that is going to fall over us. So we have this kind of syndrome. So, and then there is so much need to deliver. And by delivering, I mean cause change, with our patients and produce good results. So that's why we go and we take 3 courses per year for the 50 years of career we have, and we never stop learning. So that same thing applies to the ultrasound. So because we are entering in a way, and that's a belief from that you can hear in the physical therapy community, we're entering the waters of the MD community. We're going to be careful, and we're going to make sure that we're not overstepping the interest of the MD community, which is BS if you ask me. It is important at the same time when we deal with something so unique as ultrasound or electromyography to make sure that we know it 100%. So FMSK, that program, the goal of this program is to make sure that whoever gets into the ultrasound technology as diagnostic tool, it's going to really get out, knowing what they're supposed to know. So when they're going to have to answer an MD over their findings, they have the right answer. So I think that's what is being put together there, and rightfully so. And I believe that, before I did my first billing of ultrasound, and before I sent the first report to an MD, I really went and spent hours and hours to make sure that every word was correct, because I knew that I'm going to get some resistance from that community. And I did. In the first years when I was doing ultrasound, I got resistance from a lot of doctors. But eventually, they realized that I do also a favor to them, because I help them out too, because that's my goal. My goal is not to make money out of this, because you're not going to make a lot of money out of the ultrasound. But again, it's priceless in your patients and the relationship with your doctors. So I'm going to view, it's a great thing.
Do you want to say anything about like education or credentials or anything, Vicki, Andie?
I just want to comment on what Dr. Rizopoulos said, because I hear from PTs that they can be quite intimidated sometimes when they're dealing with, particularly sometimes with orthopedic doctors, that they sometimes look at them like, oh, your tests are unnecessary. I mean, we just had that come up with Joe and Andie when they sent us that great testimonial about how they were able to help a patient. That was EMG, but I'm just saying, I think Dr. Rizopoulos makes a good point, is that with this training, you are going to build a confidence I don't see that you could almost get anywhere else. I don't know where you would have that confidence to go into a call the same way without this type of education. That's all.
Yeah. I think more knowledge is a good thing. It's not a bad thing. And with knowledge comes power. And like, Vicki said, if you don't know something, you don't know it. Unless you really find out and put some effort in knowing more. And knowledge does give you power, because then it gives you better understanding, and automatically you're not going to be scared. Your confidence level is going to rise up, because now you know more about the patient and you feel you are in command. So it's about like really enhancing your clinical examination and knowing more about the problem, so you're better able to help your patient, or better able to direct them in the right direction if they are not candidates. So knowing more is a good thing, and it empowers everyone, whoever knows more.
It is interesting that we ran a survey on a specific group that they took courses from a specific institution, and that specific course, it was a typical 4-day course. You go for a week and you get the upper extremity, you go for another week and you get the lower extremity, and that's all it is. There is no let me review your reports, let me see how you do it. There is nothing, there is no follow-up with any of those participants, right? For those students.
Or even like covering how to write a report.
How to write a report.
What a report looks like.
There is nowhere to find out there a way to write it. So we did the survey, and majority of them, what they said, it was that they're lacking that whole hand kind of experience, that you go back and you have somebody to to call and say, hey, I have this case, I don't know how to handle it. I have this image, I don't know what exactly I'm looking at. And this is so important because most of these participants, they spend their money, they took the course. It was a great experience to just get the course, but then they stopped using ultrasound or practicing ultrasound because they felt kind of overwhelmed over the massive amount of data they had to calculate and figure out what they're looking at. So, and again, I was there. I've been there. That's how I learned, and I spent hours and months and days and scanning myself. And I think there is a better way, a faster way, and that's what FMSK is all about. And that was why it was put together anyway, for that reason.
Yes, and also like most of the programs, they have more, it's more didactic than practical. Not, we have like at least 75% or more time in the lab. So we really like put more emphasis on practical knowledge, and also practical knowledge of how you apply it to your patient, not like someone else's patient. So there are some practices they see uh, 2 or 3 body region more than others. So like, their mentorship is actually based on those cases because those are the cases we discuss. And another feature of our program is that we also have on-site mentorship. So, and which is unheard of, and no other program offers that. The mentor is physically present with you as you see the patient, and there are different levels of mentorship. You are seeing that patient together, you're analyzing the pathology together, and you can even discuss that report writing together. So that is again a huge help, especially when someone is trying to implement that classroom information to actually something that they help implement that in their practice, and are able to incorporate that into like EMR, where you write report and send it out for billing. So the entire process is covered through this program.
Can I ask a question? Because there's multiple people on here that have went through a portion of this training or all of this training. So when we're talking to people about engaging in this, and they say, you know what, I'm just too busy. I'm too busy. I don't have time. I want to say to them, this is something worth your time. This is an investment in yourself. This is an investment in your patients, and it's an investment in your practice. How did you manage during your learning processes, I guess? How did you manage as a busy PT, as a busy owner, to incorporate this training into your learning? I'm kind of curious how you did it, because that's something I'd like to share with others, as they call in to us and they have questions.
So I would love to address this.
Okay, thank you.
My story is, again, I have 3 clinics, and I treat full-time while I was going through all of this. And, at the end of the day, I wanted to know what was going on with my patients. And so I would just spend that extra. Honestly, the scanning portion is generally a fairly short amount of time for scanning for MSK. I scanned a lot of patients. Like I wanted to know what I might be missing. And then at the end of the day, I would download the scans and start looking at them. And it's amazing that, the more you look at them, the easier it becomes and the faster it becomes. And so if you just kind of front load the number of scans you do, if you do a lot early on, it becomes so much easier. So you do have to bite off that chunk of time early on, but honestly, it doesn't take that long. You just have to sort of make it part of your every day. And then as you do that, it really becomes a lot faster, a lot easier. Your eyes adjust to what you're looking at. And all of a sudden you see those 1 or 2 that something was really drastically different. And everything you've done up to that point is worthwhile. So, the answer to it is, you just kind of got to agree to yourself that it's the best thing for the patient, and you're just going to do it. And you're just going to start incorporating those extra 10 to 15 minutes of scanning with every patient, so that you begin seeing all the differentiations of different structures. And it really doesn't take that long for it to become second nature. So I hope that answered the question.
It is helpful. So your best practice, you would recommend front loading, doing a lot to get used to seeing them. You said that they'll increase, you'll kind of get your speed, because you'll kind of go normal, and then the abnormal will start popping out right away.
Yeah, I mean, I think the more you do and the more normals you see early on, it helps you to begin to see the abnormal. And so do a lot of normals. I mean, even if you're, not suspecting anything's going on. So this is our story, and Mohini and I actually, we published a paper that a patient came in and her diagnosis was a posterior tib tendon tear. She came in a boot. And the first thing she said to me is, "This boot's killing me, and can I take it off?" And I was like, "Well, if your tendon is torn, the boot should actually make you feel better. I don't really know why." So everything in her clinical examination just was sort of off. And so I was kind of like, it was an ankle, and I'd scanned a ton of shoulders. And so I was kind of like, you know what? I'm just going to scan her ankle. I don't know. And so all of a sudden I scan it, and I see that she has a huge area of black. I call it the black hole of death. She has the big black hole of death in her posterior tibial nerve. Mm-hmm. And so I didn't really know what it was because it was so unusual, but I knew that it was something not quite right. So I was like, you know what, hold that thought. And again, Mohini was super responsive as my mentor to come back, and she's like, yeah, that's a schwannoma. And I was like, oh, okay. I might see one of those in my career. I don't know, but it is commonly misdiagnosed as a tendon tear. And so I was able to immediately send her back to, she was referred from a podiatrist. And so again, that was one of those like really unique cases. But like Kostas said, I mean, that was worth all of the time and training that I'd put into it up to that point. And so she wound up being referred to a neurosurgeon who was able to excise the schwannoma. And so, like I said, I think if you just see a ton of normals and you just incorporate that, the abnormal, you don't have to look for it. You'll know it when you see it all of a sudden. So
I appreciate that you sharing that with me.
Yeah, and but now you mentioned that, Vicki, and I wanted you and Andie actually to give me your take of how your private PT practice has changed in the community, in the physical therapy community, by just implementing electromyography and sonography. How much you have changed as an entity, as a PT entity, as a PT practice in your community?
So I think that because I work in a very rural community, a very small community, and the ability for physical therapists to be a little bit more direct access, patients have the ability to come to you as more of a primary care provider. And I think that just gives not only the PT profession more confidence, but I think patients are also seeing how much you really do and how much you really put forward to their care. And the addition of the diagnostics has helped us stand out. And we've had so many success stories, just like Vicki had said, those instances where we pick up on something that maybe wasn't found before. And I mean, it's changing people's lives. And I don't think I really answered your question.
Well, you did. That's so true. But that's what I'm not going to tell you my story about that. I have my own story about it, but I want to hear it from you. And you just really describe it 100%, how much has changed you because I'm sure there are more physical therapy offices in where you're working, right?
There are. And whenever patients choose us, whenever they hear about the things that we've done and they want to come to us, it just makes you feel really good about what you're doing.
That's...
Yeah, I think it gives not only my self-confidence, but it gives the patient's confidence that I will do what's in their best interest and that I will be able to direct them in the right way. I have patients that will say, you know what, I want to come and see you and I want you to examine me and then you tell me where to go from here. Like, do you need to see me? Do I need to go to a physician? Like, what do I need to do? And so having the access to diagnostic testing that allows me to actually make the right decision as to where to send them has improved not only my confidence in myself and my clinicians, but also it has really, the public at large has had a lot more faith in just my ability to help direct them where they need to go, because entry into the medical system, especially with physicians and especially with specialists, takes a long time. It's often, months before they can get in to see somebody. And so, as you said in the beginning, Kostas, sometimes that, turnaround time, how quickly we can get them help, right, helps their recovery period. And so being able to get them in quickly and assess what's going on with them and help them navigate their way into the system is a big thing for our population here in Oklahoma, where I practice.
That's great. That's great. Mohini, what about you? Thank you, Vicki. Appreciate it.
So all of us, I think, have so many endless examples that we can give where that significantly using EMG or ultrasound significantly changed the outcomes. But I also wanted to point out that we have literature supporting what we all are saying. You can say, okay, that's your personal story and you have this success, you may be biased, but there is research and data that supports when you incorporate diagnostic tools, EMG and ultrasound separately, it significantly changes the clinical management. So if the study reports about 62% of cases where using these tools changed their clinical course or clinical management. And the study looked at the kind of impact. So, and there were grades if you just change your clinical management, conservative management, or maybe they needed something more involvement of some type of intervention, like injection and procedure or something, or someone requiring surgery, the case that Vicki just said. So that would be another category. So we do have literature supporting what we are all sharing here. It does affect your treatment. So the example that Vicki just shared, someone presenting with that kind of problem, a soft tissue mass which originates from the nerve, is very hard for someone to really find that out with clinical examination. You would think that all kind of soft tissue masses you can just palpate and find, okay, here's a nodule, but that's not true. Especially in tunnels where structures are together under the retinaculum, you cannot very accurately palpate what you're palpating there. And that's what makes it confusing. And that's why that patient was misdiagnosed, because nobody really used diagnostic tools. Even people who were capable of ordering these did not order, and so it was overlooked. And it was a wrong diagnosis and really made it, they did not get the help right away, and they had to wait longer period to really find out what's going on and get the accurate treatment, which helped significantly. So we do have literature supporting that. Just wanted to point that out.
I hear you. And it's interesting that now, as we know, there are some cases that from the examination point of view of PT, you don't need an ultrasound, you don't need an EMG, right? I mean, not all cases require an electromyography, not all cases require, sonography. So the point here is that, if you have just a muscle spasm, and now with COVID-19, as we all of us have experienced, most of our cases, they're coming in because they sit in their own chair, they have their own high of the desk, because they're on the sofa all the time, they do less walking, and they eat more. So they have other kind of problems. And most of the time, it's just muscles that they don't behave very well because the environment has changed. So these cases, I'm not going to do an ultrasound to that shoulder when I know scalenus is responsible for the pain in their shoulder, right? So point is, those cases, they're looking at me like, what about ultrasound? You're not going to ultrasound me? I'm like, you don't need that. Why charge an insurance something the minute you don't need, this tool? But it's interesting how people feel. They get so much intrigued by the ability of us looking at the problem. So from their point of view, it's always necessary, anytime they have a problem, that we got to use that ultrasound. But it's interesting how people can ask for it eventually. So that's how, at least, we have managed through the years to separate ourselves from the rest of the PT practices, because now the public is coming in looking for that extra attention through diagnostics.
Yeah, we don't advocate overutilization. So we also like put emphasis during training on indications. And again, the more you practice, the more you're like, you'll get a sense of, okay, this patient is the candidate and this patient is not. Again, we don't want it to be like considered something you use on every patient that walks through the door. So yeah, I mean, we once you go through the training, you will identify candidates for testing, and not everyone is a candidate.
Got it.
Thanks for being here.
Thank you.
Thank you.